Usually, when a patient comes in with a broken arm, the diagnostic process is, well, it's basically just engineering.
Right. Yeah, you just take an X-ray.
Exactly. You look at the X-ray, you find that jagged white line right through the bone, and you point at the screen. It's binary. It's broken or it's not broken.
It's very clean and localized.
Yeah, super visible. But for you listening today, our mission for this deep dive is stepping into a totally invisible, high-stakes world. We are unpacking the incredibly complex world of pediatric endocrine disorders.
Which is just a fascinating landscape.
It really is. We've got this amazing stack of medical slide notes and lecture transcripts to guide us. And in this space, that X-ray machine suddenly feels, totally inadequate.
Oh, completely. Because you're looking at a system where the entire body is essentially having a conversation with itself.
And we have to figure out exactly where the communication broke down.
So if you think about the endocrine system, it operates very much like a highly regulated group chat for your organs.
I love that analogy.
Right. Because instead of digital text messages, your organs are secreting these chemical messengers, hormones.
Just dropping them right into the bloodstream.
Exactly. And these hormones circulate around and bind to specific receptors to tell target organs, when to grow, when to sleep, or when to totally freak out and initiate a fight or flight response.
But the body has to know when to stop texting, right?
Yes, exactly. That's where it gets elegant. It relies heavily on positive and negative feedback loops.
The biological brake pedal.
You got it. The body constantly monitors its own serum levels. So if serum calcium gets too high, the parathyroid glands actually sense that.
And they just downregulate production.
Right. They stop pulling calcium from the bones. It's an automatic shutoff valve.
Wow. And for you listening, keep in mind that in growing children, the stakes of this group chat are, well, they're magnified exponentially.
Oh, absolutely.
A single missed text message or, an excessively sent signal, it alters their entire developmental trajectory.
We are talking about irreversible changes here. Final adult height, cognitive development, biological sex characteristics.
So to understand it, we have to start at the master control room, the administrators of the chat.
The hypothalamus and the pituitary gland.
Right, sitting right there at the base of the brain. The sources call the pituitary the master gland because it governs all the downstream organs. And its most obvious directive is physical growth.
Driven by somatropin or growth hormone.
So what happens when that specific message just doesn't send?
Well, when you look at growth hormone deficiency, the clinical presentation is pretty distinct.
The slides mentioned they grow less than 2 inches a year, right?
Yeah, and they retain normal bodily proportions, which is key. But because growth hormone also breaks down fats, these kids often have central adiposity.
Which gives them that cherubic appearance the notes talk about. Like, they look unusually young for their age.
Exactly. Delayed dental eruption, high-pitched voices. It's very recognizable once you know what to look for.
But the treatment sounds incredibly intense. The family is doing daily subcutaneous injections of manufactured growth hormone at home.
Somatropin, yeah. And the window to do this is strictly limited.
Because of the growth plates, right?
Right. It's only effective before the epiphyseal plates fuse during puberty. Once those plates calcify, that's it. No amount of synthetic hormone will make them taller.
Which brings up a huge question for me. If a kid is just naturally short, genetically, how do doctors know it's actually a hormone deficiency and not just, genetics?
That's where the diagnostics get really cool.
The sources mention a bone age X-ray of the left hand and wrist.
Mm-hmm.
Is that literally like counting the rings on a tree to see how old the bones think they are?
It is remarkably similar to that, yeah. We are looking directly at those epiphyseal plates. In a developing child, the ends of the long bones have a layer of cartilage.
And cartilage doesn't show up on an X-ray, right? It's radiolucent.
Exactly. It looks dark on the film. But as the child matures, that cartilage is systematically replaced by radiopaque bone in a highly predictable sequence.
So a radiologist is basically measuring the dark spaces.
Right. If you have a 7-year-old patient, but their wrist X-ray shows the wide, uncalcified gaps of a 4-year-old, their bone age is significantly delayed.
Wow, so the bones are literally younger than the kid.
Exactly. And that huge discrepancy is a primary indicator that they need growth hormone therapy.
That makes so much sense. And on the flip side, if the master gland is sending way too much growth hormone, you get hyperpituitarism.
Right, which causes rapid, uncontrolled bone maturation.
If it happens before the growth plates close, you get gigantism. But if it happens after they fuse, the bones can't get longer, so they just get thicker, right?
Yes, that leads to acromegaly. Enlarged hands, feet, coarse facial features.
But the pituitary gland isn't just about bones. The posterior lobe manages something even more critical.
Hmm.
Water.
Through antidiuretic hormone, ADH.
Right. And the slide notes gave us these two really helpful mnemonics for when ADH goes wrong. Let's start with diabetes insipidus, or DI.
The mnemonic for DI is dry inside.
Dry inside, so not enough ADH.
Right. In central DI, the posterior pituitary just fails to secrete ADH. Normally, ADH tells the kidneys to insert these water channels called aquaporins.
To pull water back into the blood, right?
Exactly. But without ADH, those channels stay closed. The water just passes straight through into the bladder.
Leading to massive continuous urination, polyuria.
Liters and liters of totally diluted urine, which causes polydipsia, this unquenchable thirst, and severe hypernatremia because their sodium gets super concentrated.
High sodium. And the danger for infants here is terrifying. A 6-month-old can't just walk to the sink and get a glass of water.
No, severe dehydration happens incredibly fast. Caregivers have to watch for sunken fontanelles, fast heart rate, no tears when they cry.
It's an acute crisis. Now, the standard treatment is DDAVP, a synthetic ADH, usually a nasal spray. But the sources had this amazing practical tip.
Oh, about the common cold.
Yeah. Never give a kid the DDAVP nasal spray if they have severe rhinitis or a cold. The mucus literally blocks the absorption of this life-saving medicine.
It's such a crucial real-world detail.
Right. But wait, I have to push back on something else I found in the notes.
Okay, what did you find?
The lectures say that central DI can also be managed with thiazide diuretics.
I know where you're going with this.
It sounds completely backward. Giving a diuretic to a patient who is already urinating their entire blood volume away? How does that make any sense?
It sounds like a massive contradiction, I agree, but it's actually a brilliant hack of the nephron physiology.
Okay, explain this to me.
So thiazide diuretics block sodium reabsorption early in the kidney. This causes a mild volume depletion.
Okay, so the body senses the drop in fluid and panics.
Exactly. The kidney freaks out and drastically increases sodium and water reabsorption much earlier in the filtration process in the proximal tubule.
Oh, wow.
Because it's pulling so much fluid back upstream in this panic state,
Mhm.
very little fluid actually reaches the broken collecting ducts downstream.
That is wild. So by causing a tiny leak, you trick the kidney into shutting down the main water main.
Yes, it paradoxically decreases total urine output by up to 75% in a DI patient.
Unbelievable biological engineering. Okay, so that's dry inside. The total opposite is SIADH.
Syndrome of inappropriate antidiuretic hormone, and the mnemonic here is soaked inside.
Soaked inside. So too much ADH. The kidneys are retaining all the water.
Right, the aquaporins are forced open all the time. The immediate result is dilutional hyponatremia.
Dangerously low sodium.
Yes, the total body sodium might be normal, but it's swimming in a massive excess of water. Their urine becomes sticky and thick.
And the risk here isn't just swelling, it's neurological, right?
It's a critical neurological threat. The extracellular fluid gets so diluted that osmosis drives water directly across the blood-brain barrier.
Into the brain cells.
Yes, the brain swells inside the rigid skull. This leads to confusion, hallucinations, and a profound risk of seizures.
Which is why the treatment is strict fluid restriction and sometimes hypertonic saline to pull that fluid back out of the brain.
Exactly. You have to very carefully reverse the osmosis.
Okay, so once the master gland stabilizes the water, the body needs a baseline metabolic rate. It needs an internal engine.
And that brings us down to the neck, the thyroid gland.
Right. Responding to TSH for the pituitary. When the thyroid fails, we see two totally different metabolic states. First is hypothyroidism.
The notes characterize this as low and slow.
Cold intolerance, weight gain despite not eating much, constipation.
Right, because without T3 and T4 hormones, cellular energy production just grinds to a halt. You see severe fatigue and a slow heart rate.
And if it goes untreated, you get this terrifying complication called myxedema, which is not just normal water retention, is it?
No, it's very different. The lack of thyroid hormone alters how the skin metabolizes carbohydrates.
Oh, interesting.
Yeah, so these complex molecules build up in the dermis and they draw in water. It causes a non-pitting edema.
So like facial swelling, a swollen tongue.
Macroglossia, yes. And eventually a myxedema coma.
Okay, so flip that. Hyperthyroidism, usually Graves' disease in kids. This is the engine redlining.
Hot and high.
Right. Massive amounts of hormone, heat intolerance, sudden weight loss, fast heartbeat, and the eyes. Right. Exophthalmos.
Yes, the bulging eyes. The autoimmune antibodies actually attack the tissue behind the eyes, pulling in water and physically pushing the eyeballs forward.
That is intense. And the big danger is a thyroid storm.
Where the hypermetabolic state just spirals completely out of control, severe hyperthermia, cardiovascular collapse.
It's like driving a car stuck in first gear versus one constantly redlining. But wait, going back to the low and slow engine.
Hypothyroidism.
Yeah. How do we catch that in a newborn baby? I mean, babies basically just sleep and eat anyway, right? It seems like it would be invisible.
It is often completely asymptomatic at birth, which is why it's so incredibly dangerous.
Because they still have mom's hormones from the placenta.
Exactly. They look neurologically perfect at delivery. But once that maternal supply runs out in a few weeks, the infant's brain is starved of the hormone it needs to develop.
Oh, wow. So if you wait for symptoms, it's too late.
Irreversible cognitive impairment has already happened by the time you see the lethargy and hypotonia.
Which is why the mandatory newborn screen is a massive systemic safety net.
It's one of the greatest public health interventions we have. Every state mandates a heel prick blood test within days of birth.
They're testing the TSH levels, right?
Yes, looking to see if the pituitary is screaming at a broken thyroid gland. If we catch it, we just start them on oral levothyroxine.
And they have completely normal development. Just an amazing win. Okay, so if the thyroid is the daily engine, the adrenal glands are the emergency responders.
Managing stress and salt, sitting right on top of the kidneys.
But sometimes their internal feedback loop breaks down entirely. The sources dive into congenital adrenal hyperplasia, or CAH.
Right. This is where the adrenal glands cannot produce cortisol.
Our main stress hormone.
Exactly. Usually due to a missing enzyme, 21-hydroxylase.
So the body is shouting for cortisol. The brain senses it's missing, so it just screams for more.
It pumps out ACTH, relentlessly stimulating the adrenals.
And the factory is broken, so it just builds more assembly lines, the glands enlarge, hyperplasia, but it still can't make cortisol.
Right. The precursor materials build up like a dam blocking a river. The water has to go somewhere.
So it gets shunted into a different pathway.
The androgen pathway. The adrenals inadvertently flood the body with excess testosterone.
Which has striking physical manifestations at birth.
It does. Female infants are often born with ambiguous genitalia.
The notes said enlarged clitoris, fused labial folds, masking that they are genetically female.
Right, even though their internal organs are normal. And male infants often show early puberty later on.
But the immediate life-threatening danger isn't anatomical, it's the salt.
Yes, because they also lack aldosterone, they enter a salt-wasting crisis.
They just pee out all their sodium.
Massive amounts of it, pulling water with it, leading to fatal dehydration very quickly.
So how does a family manage a child who has absolutely no natural stress response? If they get the flu or break a leg, they can't produce cortisol to handle the shock?
They will go into circulatory collapse. So this requires a protocol called stress dosing.
Manually overriding the system.
Exactly. The parents have to actively intervene. During an illness or trauma, they double or triple the child's daily steroid dose.
To artificially mimic the biological stress response.
Right. And if the kid is vomiting, the parents have to give an intramuscular injection of hydrocortisone. It's very high stakes parenting.
Unbelievable pressure on the family. Okay, we've covered growth, water, metabolism, and stress. But none of this works if the cells can't access their basic fuel, glucose.
Which brings us to the pancreas.
The fuel processors. The pancreas makes insulin, which is literally the key that unlocks the cell door to let glucose in.
Exactly. And in type 1 diabetes, an autoimmune reaction destroys the beta cells that make insulin.
So you have zero insulin, the glucose is trapped in the blood, and the symptoms are classic. The polys.
Polyuria, massive urination as the kidneys try to flush the sugar.
Which causes polydipsia, severe thirst.
And polyphagia, extreme hunger, because the cells are literally starving even though the blood is full of sugar.
And if they don't get insulin, the body panics and breaks down fat for fuel instead.
Which releases highly acidic ketones. The child enters diabetic ketoacidosis, or DKA.
You see that Kussmaul breathing, right?
Deep, rapid, labored breathing. The body is desperately trying to blow off carbon dioxide, which is an acid, to fix the blood pH.
And their breath smells like fruity acetone. It's a massive medical emergency. But we also have to talk about type 2 diabetes.
Which we are seeing a sharp rise in among pediatrics, unfortunately.
Due to obesity and sedentary lifestyles. In type 2, they have insulin, but the cells are resistant to it.
Right, the receptors are blunted.
Now, I saw something in the notes that I really wanted to bring up. We hear about type 1 a lot, but type 2 sneaking up on kids is alarming.
It is.
The notes mention this massive, highly visible check engine light for parents that often just gets totally missed. Acanthosis nigricans.
Yes. Dark, velvety, thickened patches of skin.
Usually on the back of the neck or the armpits, right? Sometimes people think it's just dirt.
But it's actually a direct physical marker of severe insulin resistance.
How did that happen?
Because the cells are resistant, the pancreas pumps out massive amounts of insulin to try and force the sugar down.
Oh, so the excess insulin causes the dark patches.
Exactly.
Yeah.
It cross-reacts with growth receptors on the skin cells, causing them to rapidly multiply and darken.
Wow. It's literally the body sending a physical text message onto the skin asking for help.
Any child presenting with that needs immediate metabolic screening.
So how are we managing all of this today? It's not just syringes anymore. The modern management, especially for type 1, relies heavily on insulin pumps.
Right, these small computerized devices that mimic a real pancreas.
They do a basal rate, like a continuous microdrip, and a bolus dose, a big surge right before meals.
It's incredible technology, but severe hypoglycemia is always a risk.
Right, if a kid gets a bolus dose but then doesn't eat, their blood sugar crashes. The sources are very clear on the emergency protocols here.
Very strict rules. If the child is conscious, you give oral carbs.
Like squirting glucose gel into their cheek.
Right, but if they are unconscious or seizing, you never put anything in their mouth.
Choking hazard.
Exactly! You have to give an intramuscular injection of glucagon.
Which basically tells the liver to dump all its emergency sugar into the blood right now.
Precisely. It forces them back into consciousness.
So, stepping back, we've journeyed from the master controls of the pituitary down to the cellular fuel of the pancreas.
It's quite a trip.
The human body is just constantly talking to itself.
Ugh.
Extreme thirst, stalled growth, dark patches on the neck. These are all just physical text messages that the group chat is failing.
And, it leaves you with a really profound thought to mull over.
What's that?
Well, we just talked about how synthetic hormones and insulin pumps artificially mimic these natural rhythms.
Right, we're replacing the biological messengers.
Exactly. But now we have insulin pumps that continuously monitor blood sugar in real time, and they can automatically text a parent's smartphone via Wi-Fi if the kid's levels drop.
Oh, wow.
Right. So we are essentially building a digital, Wi-Fi-enabled extension of the human endocrine system.
That is wild to think about.
It really is. It makes you wonder, where exactly does the biological feedback loop end and the technological one begin?